Hi, everybody. Hope you can hear me okay. Let me just adjust my mic there. Okay, hope that's a bit better. Okay. Sorry about that. I was just adjusting the mic so that you guys would be able to hear me. Pointing the wrong way. All right, so we have another ECG one today, and not a very difficult one, but just one that we should have a look at, just so that we can. It's something that you may see from time to time in your practice, so it's something that you need to know about. So this is the ECG. So we got a 45-year-old man with severe lightheadedness. Now, of course, lightheadedness in itself may not reveal much, but let's assume that this patient had come in, and one of your decisions was to do an ECG. Maybe he's hypotensive, which is not a good sign. The patient has got signs of a TIA or, diminished consciousness, or he's having chest pain or whatever it may be. So you decide to do an ECG, and this is what you see. Now, if you work, like most of our guys who work over here, let me not say that shit. But this is one of those that when you see this, you may get a bit scared and think, oh my God, what is this? What am I looking at? What do I do? So let's have a look at it and see. Let's analyze it bit by bit, and then we'll take it further. So let's look at everything in order. So let's do that on the next slide. It's not a very long presentation. Been giving you guys some long ones recently. So this was just a bit of a short one just to try and catch up. So the first thing we do is look at the axis. So we look at leads 1 and AVF. Let's draw that out. Right, so let's put our axis lines there. So let's make it a bit thicker. It's quite thin. I'll be able to see it. Okay, so let's put our lines there. Right. So I hope you guys will be able to follow along. If you're not following along, please remember to go back and have a look at the basics of ECGs. Then we'll take it from there. So that's lead 1 and AVF. All right, so let's look at which way lead 1 is pointing. So lead 1 is negative, right? So that means electricity is moving away from it. So it's either in the extreme right or the right. Okay, those are only two choices. We know we don't have a normal or left-sided axis. And if we look at AVF, AVF is pointing upwards, meaning that electricity is moving towards it. So this is our axis. We've got a right-sided axis. Okay. So a right-sided axis is one of those things that can give you a clue as to what's going on. It means either the right side of the heart is pulling too much of electricity, or the left side is damaged for some reason. And there are one or two exceptions to that, and I think today we'll cover one of the exceptions. Let's have a look at our our rhythm. Right. So the first thing we're going to try and do is try and look for a P wave anywhere here. So the question is, do we see any P waves? And the answer is no. So we don't have a P wave. So already we know we don't really have a sinus rhythm per se, all right? But anyway, you don't need to really go through it. You can already see, but we're trying to analyze it. So let's try and have a look and see. So we know we've got a right-sided axis. We've got no P waves. So we can't talk about a PR interval. We can't talk about QRS coming after every P and things like that. But what do we have? We have very wide QRS complexes. So if you look at them throughout, these are not narrow. Even though they start off narrow, they end up actually being quite wide. So from the start of your Q, in this case, your R wave to the end of your S wave, it's extremely wide. Okay, there we can see it again. Here we only have an R wave, or we have again an RS. Here we have a QR. Wherever you look at it, it's quite wide, it's quite wide. And that should tell you something already. So when you start looking at that, now you've got to start thinking to yourself, all right, so I've got no P waves. So what does that tell me? It tells me the atria is not really involved. The atria is not really functioning. Okay. But I do have wide QRS complexes. So if you guys remember from all of the talks we've had, if you have narrow QRS complexes, it tells you that your signal is originating from the atrium. And if you have a wide QRS complex like what we have here, it means that the ventricle is the one that's actually providing the pacing. So what it means is that there's no input from the SA node, which is essentially your P wave. And input is only coming from the AV node, which is what causes this large or wide QRS complex. Okay, so we've got a ventricular abnormality. Let's look at it like that for now. Got a ventricular abnormality. Okay, are they regular? they're relatively regular if you actually look at them here. Even the voltages may change. And here they talk about it being at half standard, because if it was it just means that they've adjusted the settings on their machine. Otherwise, these would be much longer and they would basically make it difficult for us to see everything. So that's why they adjusted it to half standard. So we've got this regular ventricular movement. So we've got something that has to do with the ventricle. Now let's go to our rate. So we've got a rate of just about 150. Let's say just about 150. So we've got a tachycardia that's coming from the ventricles. I think you know where we're going with this. So this is a ventricular tachycardia. If you guys can hear me, this thing's not, I hope it's picking me up okay. Okay, so we've got a ventricular tachycardia that's going on over here. Okay, so this is the easiest way to pick it up, right? Width of the QRS complexes, absence of P waves, which is the most common finding. And then, of course, you see this regularity. Right? So we have a relatively slow ventricular tachycardia, but nevertheless a ventricular tachycardia. Okay. And then if we have to look at each zone, now remember, we're not really looking for ischemia in this case, but we would look for any abnormalities that we could pick up. Now, in this case, what I can tell you is that this is actually a hemiblock that's occurring as well. As far as I can see, there's a bit of a hemiblock as well. But that's not the important part. The important part is the fact that we have now a patient with ventricular tachycardia and severe lightheadedness. All right. So do you think this is a stable patient, an unstable patient? That's what you need to ask yourself. And that's what we're going to talk about in the next little while. So we've got a ventricular tachycardia. They've put the rate at 135. So it's a relatively slow ventricular tachycardia. Now, I must be honest, ventricular tachycardias can be extremely fast. They can go up to 200, 220. Your supraventricular tachycardias tend to sit between 150 to 100. So the reason for this is actually like I told you, there might be a bit of a bundle branch block, and that's preventing the rate from actually climbing up a bit higher. But that's a bit more complex. I'm not too worried about that. Right? So the rhythm is a wide, complex, regular tachycardia. So the differential diagnosis includes sinus tachycardia with aberrant conduction, supraventricular tachycardia with aberrant conduction. Now, aberrant conduction means that you've got bundle branch blocks as well, which are also suspected over here, and ventricular tachycardia. So the absence of sinus activity rules out a sinus tachycardia. The rhythm, therefore, should be assumed to be ventricular tachycardia and treated as such. Okay, and the presence of a rightward axis always strongly suggests the favor of ventricular tachycardia. Right. Now, after that, electrophysiological studies confirm the diagnosis of VT. Now, for those of you who have been watching for quite some time, or who may be moving on with their ECG studies, and for those of you who don't catch the next, don't stress about it. Right. So why wouldn't we call this an SVT with aberrant conduction? Let's go back. So there's a few things that would actually put us would take us away from that. Right. So one of the first things is that generally with SVT with aberration, you tend to see more of an advanced block than what you're getting over here. And there tends to be what we call concordance. Now, concordance means that you've got all of them facing in the same direction. Whereas in this one here, we can see there's something called discordance, where we've got some pointing in one direction, some pointing in another direction, and so on and so forth. So that's just two of the differentiators. But if you were to make a distinction, if you were to say it was SVT with aberrant conduction, and you were to abnormally, let's say, call it a VT by mistake, it wouldn't cause much of a problem. Now, if you didn't catch all of that, don't stress about it. The most important thing is to know that this is a ventricular tachycardia. So what happens when we get a ventricular tachycardia? Now, the thing we need to discuss, is this a stable or unstable patient? So the diagnosis in this ECG, relatively easy, but the question is, what do we do if this patient is stable or unstable? So let's start with the stable patient. So what tells us that the patient is stable or unstable? These are the factors, okay? Now, this algorithm is quite large. I don't want to concentrate on all of it. So is the patient hypotensive? That is your most important differentiating factor. Is your patient hypotensive or not? So if your patient has hypotension, low BPs, they will start developing the rest of these, okay? Your patient can't have the rest of these without hypotension, majority of the time. There are exceptions, of course, right? So if your patient has a low BP, you consider them as unstable. Does the patient have signs of shock, which will be related to hypotension, acute altered mental status, which is also a result of decreased cerebral flow, chest discomfort, which is also a result of what you call it, decreased what you call it, pressure within the coronary arteries, and acute heart failure, which is also a result of hypotension. So you're looking at your BP. If your BP is normal, you treat your patient as stable. Now, if your patient is stable, what are you going to use? So what we're going to do, we have a look here. So if we have narrow, which we don't have, then you would consider adenosine. But if you've got wide, like what we've got over here, and what we do as well, is we normally start these patients with amiodarone. Okay. Now, adenosine you can give as well. There's no doubt about it. But I must be honest, as I've told you before, it's a very difficult drug to give, and it hasn't really worked that well in my experience. So we also start with amiodarone. Tend to give them 150 milligrams over 10 minutes, and you can give it as much as is needed, but amiodarone does have its own side effects, so generally you won't keep on giving it beyond that. Okay, so you've given your patient amiodarone, you've decided that they are unstable. So if the patient is unstable, you'd actually skip the step over here and you would go to synchronized cardioversion. Okay, so you wouldn't worry too much about that as well. In fact, that would be our second step, sorry. So what we're actually trying to say is that we want to do synchronized cardioversion. If your patient doesn't have signs of these, so in other words, your patient has a stable VTAC, then you can try other methods, as what they mention over here, right? Which is antiarrhythmic infusion, such as amiodarone. You can give adenosine. You can use vagal maneuvers, beta blockers. But we're going to assume that our patient was unstable because he actually had signs of hypotension. Let's say the lightedness, acute altered mental status. Okay, let's take it as that. So the question is, how do you do a synchronized cardioversion? So let's go into that and see.
With synchronized cardioversion, you deliver a shock synchronized to the R wave of the ECG being monitored in wave sector 1. You can monitor and perform synchronized cardioversion through the multifunction electrode pads or external paddles. Or you may choose to monitor the ECG through monitoring electrodes connected to a 3, 5, or 10 lead ECG cable with the energy delivered through the pads or paddles. In this case, we'll assume we have prepared for both monitoring and synchronized cardioversion using the multifunction electrode pads and have a clear signal and large QRS complex. With the therapy knob in the monitor position, press the sync button to activate the sync function. This message appears. Confirm that the sync marker appears with each R wave. Turn the therapy knob to the desired energy level setting. Press the charge button on the MRX. Make sure no one is touching the patient or anything connected to the patient. Press and hold the shock button on the MRX. A shock delivers on the next detected R wave. You can deliver additional synchronized shocks simply by pressing the charge and shock buttons again. Disabling the sync function is as easy as pressing the sync button.
So I love how calm they were. If only it were like that in real life. In real life, we tend to run around like headless chickens when you have to do a cardioversion. So when you have to do a cardioversion, I would suggest that you sedate your patient ever so slightly. Give them a bit of dormicum or morphine. It can be a very uncomfortable experience. And the question is, how much do I use? So the reason why we we use synchronized cardioversion is that we're trying to stop the heart at its maximum contraction. So that's why you're hitting it on the R wave. So if you stop that contraction just there, it completely relaxes in the hope that it will restart again. But if you hit it at any time, you may hit it at a point of complete relaxation, in which case you'll stop the heart completely. It won't be able to restart again. It's actually a nice thing to read about if you have a chance. What you would call it, the thinking behind cardioversion, synchronicity, non-synchronous. things like that. And maybe I'll have to do a little presentation of that, because it's actually quite interesting. When you understand it, you'll never forget how it needs to be done. So these are your values for what you should be aiming for. Now, if you see anywhere monophasic, just ignore it, because we don't really use monophasic machines anymore, unless you're in a very old hospital or somewhere that's really rural. You may not find this. But in this case, we're looking at a wired regular. You'd start off at about 100, but you go up to 130, 150, have gone up to 200 on some patients. So the reason why they say press and hold is because you must remember you're only hitting the heart on the next beat. So if you press your shock button in between beats and immediately lift off, you may not actually get the charge go off at that stage. So as compared to a normal, what you call it, defibrillation, where as soon as you press the shock buttons, you get your discharge. This one here, it may take a millisecond or two. So just keep your hands on the patient just to make sure that it does actually cardiovert the patient. And we've done this now a few times and always had good success with it. So it's a good therapeutic tool to use, and it really does help. So I know today was a little bit short, and it's a discussion that we've had a few times before. So I'm not too stressed about going into too much detail. We've discussed VTACs and we've discussed a lot of things like this before, but I just wanted to give you guys just a little bit of a tutorial on the cardioversion as well. Excuse me, just a little joke to finish up. So if there's any issues or any questions, please let me know. But this is a nice, simple topic that people should know as soon as in other words, you're day one in an emergency department, you should know how to diagnose and immediately treat an unstable VTAC. All right, guys, bye. And like I say, any questions, just let me know. Bye.